Hi everyone, my name is Natalia Cardoso. I'm from Brazil, and I would like to start thanking Dr. Ayman Fakri and Sohiel and all the Egyptian Forums for inviting me for this great webinar. I'll be talking about the diagnostic roadmap for pelvic congestion syndrome, which is such an important topic, and I'm glad to be here to talk about it. So why pelvic congestion syndrome matters? We know that up to 30% of chronic pelvic vein can be caused by pelvic varicose veins, and this has a major impact in the quality of life of these women, and it's quite frequently misdiagnosed. So this is important for us to think beyond the gynecology on chronic pelvic pain, also to think venous. And the first step is the clinical suspicion. We are going to suspect with these patients who has chronic pelvic veins with over 6 months that a pain that worsen with standing, postcoital, and that gets better when supined. And also these patients could also have associated findings such as vulvar varicose veins, atypical leg varicose veins, and also dyspareunia. And in these patients, it's important to have this roadmap. And the first step is to suspect. Do I suspect that my patient have pelvic congestion syndrome? Then I can lead up to the diagnostic road, initiating with ultrasound and also leading up to other more advanced image techniques such as CT, MRI, to develop and study the hemodynamics of these patients, also do venography, and then classificate and decide upon which is the best treatment. We all know that the ultrasound scan is the first line in imaging. It's dynamic, accessible, but also operator dependent. So it's important to have trained physicians to do the diagnosis of pelvic varicose veins. And here I'm going to dissect a little more of the protocol that our group recent published on the Venous Journal of Venous Vascular Surgery, Venous and Lymphatics. We defend a four-step diagnosis of pelvic varicose veins with the venous mapping, the transperineal, the transabdominal, and leading up to the transvaginal is open access. You can also access with the QR code here. So us as vascular surgeons, we have some clinical blind stops. When we are treating those patients, sometimes we have recurrences, and it is a reality. In the study that we published, we found that 52% of patients with pelvic venous reflux also presented recurrent varicose veins. We have this anatomical link, so it's important for us to have this paradigm shift. When we are routinely mapping those legs, we cannot ignore the infradiaphragmatic reservoir because we can lead to more recurrency in our cases. So we do a four-stage ultrasound investigation protocol for our patients. The stage one is going to be the lower limb mapping, the stage two, the transperineal with the pelvic escape points, the stage three, transabdominal, stage four, the transvaginal. Our objective with this protocol is to visualize continuous venous flow and the pelvic sources and comprehensively map the interconnected infradiaphragmatic venous reservoir. The average time that we take doing this protocol is 60 minutes. The first step is the venous mapping that we do as vascular surgeons every day. We study the saphenous trunk, and we also do the varicose veins. And we also often say that those varicose veins will lead you to the leak point, the connection between the pelvis and the leg. As you can see here, when we are following varicose veins, it leads us right to the perineal point. It's important for us to identify that on the legs, the pelvic origin reflux is predominantly non-saphenous. We can have distant distribution patterns to serve as a physical indication to initiate deep pelvic investigation. But when you have a typical varicose veins, non-saphenous varicose veins, we can turn our eye that this has a pelvic source. Also, when we are having a typical disguises such as neuro and lymphatic connections, the sciatic nerves, veins, We can have also leading up to pelvic connection point, and also veins in the lymphatics. We can have them often associated with the ignal escape point, so it's important for us to look for it too. For the second stage of our venous protocol, we do the transperineal study, where we look for the pelvic escape points. The most common one is going to be the perineal, followed by the inguinal, and also we have the gluteal, and the last common is going to be the obturator point. And it's important for us to know how to identify these patients, these points, and the patients could be done standing or even sitting with the thighs slightly flexed. And in our study, we found that 86% of the patients who had a pelvic escape point had pelvic varicose veins, which is a very high frequency. So it's important for us to know where to look for these points. So where are the pelvic leak points? They seem hidden, but once you know the anatomy, they are quite easy to find. So the main leak points, we have inguinal, obturator, perineal, and gluteal points. They are all shown in this picture done by Joanna, a friend of mine. The first point that I'm going to talk about is the inguinal point. It's going to be in the inguinal canal, so you're going to see the veins that are following the round ligament in the inguinal canal. It's going to be a connection between the pelvis and the our limb. So when we are doing the scan of the leg, when you see the saphenofemoral junction, and we do the look up to our transducer, doing above the ligamental ligament, we're gonna see the inguinal point. The inguinal point, as you can see, they are curved, have this concave, like a common sign. So it's quite easy. And when we ask the patient to do the Valsalva maneuver, you're going to see the reflux. So we have this concave image, varicose veins along the inguinal canal. And when doing the transvaginal, we identify the pelvic varicose veins. The obturator point is going to connect the limb with the obturator veins. So we're going to see them right below the saphenofemoral junction. It's going to be between them. On the ultrasound, if we are looking with the transducer, comparing with the inguinal point, with the inguinal point you go up the saphenofemoral junction, and the obturator you're going to look down. When we ask the patient to do the Valsalva maneuver, you're going to see this vein that it kind of dives deep into the muscles. And this is the again, obturator point. So when the patient do the Valsalva maneuver, you can see the varicose veins. The perineal point is the third point, the most frequent one, and it's going to be located a bit further down on the 2/3 of the major labia. You're gonna see this perineal point, as you can see here in the anatomy. You can also see some varicose vein leading up to the major labia. And when we ask the patient to do the Valsalva maneuver, you're gonna see these big veins connecting with the pelvis as well, as you can see here when we ask them to do the Valsalva maneuver. And we can also have around the vagina the clitoral point, with this anastomotic plexus between the bulbar venous and the clitorius, and we can find reflux in it, and on the same side that can lead to varicose veins on both sides of the grand labia of the vagina, and also can put this reflux in the great saphenous trunk, so it's important to look for it. You can also see the both perineal points when we are putting the transducer in the Alcock canal. Then you can see on both sides of the vagina the perineal escape point, as you can see here in this image done by ultrasound. And the last point is going to be the gluteal point, which as the name says, is going to be on the gluteal line, connecting with the gluteal veins. It's posterior, can be connected with sciatic nerve varicose veins, as you can see here in this case. When we are following the nerve, we're going to see the varicose veins, and when we are following them, they can be connected for the pelvis with the gluteal point. And as you can see in this patient, this is the gluteal point. We ask them to do the Valsalva maneuver, and then we can see it. And when we've done the transvaginal ultrasound of this patient, we also confirm the pelvic varicose veins. The third stage of the transabdominal assessment, and this patient we're gonna look for the assessment of the iliac and renal venous compressions, also identify the gonadal vein and its caliber. As you can see, these are the veins that we are going to study. We're gonna see if there's compression of the left common iliac vein, check for compressions on the left renal vein, and on the gonadal vein we're going to see the flow direction and also the diameter of these patients. And the last stage is going to be the transvaginal ultrasound, who can be more difficult for us vascular surgeons, but with training you're going to see it's quite easy. We're going to see the parametrial vein diameters that can be over 7 millimeters to do the diagnosis of pelvic varicose veins. As you can see in the image, they are quite easy, big veins that we're going to see when we do the transvaginal ultrasound, and it is mainly what we need to see as a vascular surgeon doing this investigation. We also have a scan, this report that's easier to identify, and it's free. It's also on the publication. We in this our study saw that patients who had the larger plexus, uterine plexus, the diameter of the vein, it was related with more dyspareunia. It's important for us to look for the recurrence. And in our services, if we don't have ultrasound scanners who are trained to see pelvic varicose veins, you can also do other kinds of image to confirm this dilation, such as MRI, CT. Also venography is important to identify reflux that is different from obstruction, that is critical for when we are planning to treat those patients. The venography still stands as the gold standard imaging for these cases, where you can see real-time reflex visualization. So it's important to on the algorithm of this patient is to suspect. Do the ultrasound, that can be sufficient, but if not, you can also confirm with CT, MRI, and venography. And it's important to treat the patient, not the image. Dilated veins on the pelvis are different. The pelvic congestion syndrome, we can have asymptomatic cases, we can miss obstructive causes, and the main causes we cannot underdiagnose. So the take-home message is to suspect clinically, do the image diagnosis, we can do venography, and not forget it is a multifactorial disease, and to remember that not all pelvic pain is gynecologic. Also, thank Venus, I have the happiness to work with amazing women researching pelvis, and I'm very thankful for this invitation and look forward for the discussion. Bye bye.